Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to another episode of Paw Patrol with your host, Dr. Jeff Dikis. Today I am joined by two current fellows at the Core Institute in Phoenix, Dr. Grant Schindler and Dr. Becca Varney. Thanks for joining me, guys.
Thanks for having us.
Yeah, happy to join.
So, Becca, why don't you kind of tell everyone kind of your backstory and how you ended up here in fellowship, kind of tell them where you went to school and residency and kind of walk through that process.
Yeah. Well, I guess originally I went to the University of Pittsburgh for my undergrad, studied rehabilitation science, and I've always loved sports type medicine, biomechanics, all that good stuff. Went to Temple for podiatry school and Nova for residency, focused on a lot of rear foot reconstruction and trauma. And then now we're at the Core Institute where, again, a lot of rear foot recon, a lot of sports, trauma, and especially total ankles here.
Sure. And Grant, how about you?
I went to the University of Sioux Falls in South Dakota. From there, went to Temple University, where Beck and I were classmates. Then over to Portland, Oregon at Legacy and Kaiser Permanente, kind of combination between the two. And then now at the Core Institute. So really like kind of transitioning from more hospital-based over to the orthopedic side of things. So it's been a really nice kind of transition.
Sure. So for anyone just listening, Grant is actually in the rainforest, and you are hearing monkeys, and I think, was that a toucan? I'm not sure.
I think so.
So he's in the rainforest. I can see it right now. So, all right, thanks for joining me. I think this will be really helpful because, most of the listeners are, all over. I've had people come up to me and introduce themselves, and all different kinds of people, way more than I ever thought would listen. So, but this one is kind of geared towards educating people about fellowship, students thinking about it, and then residents that are kind of in the midst of it and trying to figure out if fellowship is for them. The number of fellowship seems to be increasing for better or for worse, because you guys would probably agree there are some really, really great fellowships and maybe some other fellowships out there that not horrible. I don't know them, but maybe not quite as good. So Becca, what made you decide that you wanted to consider fellowship?
For me, it was just kind of a personal drive. I'm kind of the person that I always want to be trained to the highest of my abilities, kind of learn everything that I possibly can, so that I can treat patients better. So that was really it for me. I never felt like I was lacking from my residency experience. I just really wanted to build upon it. That's pretty much my reason. I think there's a lot of different reasons why residents can go to fellowship. One of them being just training just because they want to be the best. One of it could be, in their residency, maybe they didn't get exposure to a particular field of podiatry that they wanted to. For example, if you love limb salvage and you didn't get that in residency, you can totally do a limb salvage fellowship. For me, it's just extra training and total ankles.
Yeah, I think that's a good point. Grant, how about you? The biggest motivating factor for me was mentorship. Like I have this massive sports background, and having more reps, more practice, increase my proficiency, increase my exposure, and increase my mentors' life. So the ability to, work with more people, like when you get into residency, you really kind of hone in on that skill set. A lot of the attendings at Legacy were from Legacy. And so it was really good to have that learning style that was really consistent throughout, but then also wanting to advance that and have a different thought process. So coming down to core, having that different exposure and different thought process, it has been really good to kind of get a sense of, hey, how do these things go together even when you're coming at them from different ages?
Yeah, so that's a good point. So I don't think anyone would ever say that additional training is a bad thing. And at this point of your career is when it makes the most sense. It would not make very much sense if you went to residency and then went into practice, and then 5 years later you took a year off to do fellowship. That wouldn't make much sense. You'd have patients established, you'd have a career, who knows, plus or minus family and kids, and set up in this location. So if you're going to do it, I mean, the timing obviously makes sense to further your training right after residency. So Becca, what made you decide on core specifically? Because I assume you probably looked at maybe all the fellowships or at least some of the fellowships, but what made you decide on that one particularly?
Yeah, I mean, I don't know how many fellowships there are now. I probably looked at 10 specifically. And I think I applied to 6, interviewed with 4, something like that. But for me, core, it's really about the kind of experience that you're getting here. So I know I keep saying this. I hate to beat a dead horse, but total ankles. It's one of the things that, yes, I got exposed to. I think I did probably 30 in residency, but would not have felt comfortable coming out day one doing one. And I think that's the kind of procedure that's in our field, you just need advanced training for. It's not something that you can just, follow a cut guide and do. You need to understand how to manage the complications, et cetera. So I wanted particular training in total ankles, trauma as well. And then the attendings. Something that's different for me from fellowship versus residency is in residency, we had maybe 40 attendings that we worked with. And in your third year, you just chose whomever you wanted to work with for that day and you picked your cases versus here. More similar to what Grant was talking about. It's more of a mentorship. The attending that I'm with Dr. Scott, I've been with him for the last 3 months, every single day, every day in the OR, every day in the clinic. So you really get a good continuity of care and learning how a specific attending does something. And then honestly, I think, region plays a role. The weather in Phoenix, you can't really complain. It's, high 90s right now in October, sunny. So not a bad place to be.
Yeah, for sure. So Grant, why don't you walk us through the application process, kind of from a timing standpoint of when you start looking into fellowships and evaluating, and then how the timeline runs from when you do what?
So I was probably pretty late to the game. I started having a lot of conversations with different fellowships probably around Christmas of my second year. That's when I wanted to make the decision of really deciding to go down the route of a fellowship. But I think the earlier that you can take a look at it, I know you don't have as much exposure, and as you go down in residency, especially in your third year, you have more exposure to high-end reconstruction surgeries. But I wanted to take a look at like what I saw the third year residents doing, and I wanted to see where I would be at and what I was exposed to. So I think, coming around this time of your second year, starting to look at ACFS and or DPM, and looking at kind of when the application cycle ends for the different programs, trying to get in contact with the current fellows or previous fellows and talk to them about differences between their program and other programs. And then I ended up going down to ACFAS my second year to then meet the directors and try to meet some of the fellows and have those conversations. But each year, it seems as if things have gotten earlier. I know Becca and I interviewed late May or early June, and I know some of those timelines have even moved up to early May. And so as it seems each year, it gets sequentially earlier. So I think honestly now for the second years, they should start looking at different programs and honing in on like where they would like to go. I think it's one thing casting a wide net is almost too much, where Becca and I think we're very similar, where we only applied to 5 or 6.
Becca, is it a centralized application process, or is it just a free for all with each program and you contact each one directly?
Man, that's actually kind of a hard question to answer. It's pseudo centralized. So within fellowships themselves, there are ACFAS fellowships, obviously run through the college, and then there are non-ACFAS fellowships. The non-ACFAS ones, I guess, are not centralized. Technically, ACFAS fellowships are centralized, There's a standard application that you have to fill out. However, every program will have different requirements in addition to that central application. One program wanted 3 letters of recommendation versus another only needed 2. One of them wanted all of my case logs in addition to my application. Someone an essay instead of a personal statement. Like there's always just very small specific changes that are different between the programs. The only way to find that out is to go directly to those programs kind of fellowship page. So essentially what I did is through word of mouth, I found, I heard of the programs that I thought matched the criteria that I was looking for: heavy recon, total ankles, great attendings, etc. So I found those programs, I looked at their websites, and then kind of made contact lists of who I needed to reach out to, who the past fellows were, and then what the additional requirements for their fellowship were on top of the ACFAS requirements and their application due date. Like Grant said, those due dates are unfortunately changing all the time. I remember specifically there was a program that I had applied to that said on their website, it said the due date was October 25th, and it was actually like back in June. So it's not always up to date, and it's something where you really need to start reaching out early. I would say if you're a second year, you need to, know that you want to go to fellowship and have a list of programs that you'd be interested in applying to, and know who they are and contact them usually by ACFAS of second year. ACFAS is late this year, so I would probably know by January, February, where you'd be interested in going to.
One of the other things too is some programs do require a visit, because when you start to take a look at fellowship, it's a much smaller group of people that you work with. So it's a feel thing. If you're going to be with someone like Becca was saying, she's with Dr. Scott every single day in and day out. So it's also like matching of skills, but also matching of personalities. So a lot of programs do require visits to have that formal introduction.
So right now it feels like the fellowships are a little bit of a free for all. Just, some people accept their fellows years in advance, some don't, some have open interviews, some, is more word of mouth. Do you guys think that it should, if we're going to fix that issue of fellowships, do you think that it makes sense to bring it in to be centralized and be more similar to the residency process where they're all on the same timeline, that they maybe have a centralized interview? Maybe they hold them at ACFAS. I don't know. There's some sort of centralized interview process where you can kind of streamline all that. Do you think that would make sense to you guys? Did it feel discombobulated trying to keep all this stuff straight, Becca?
Yes. It was very difficult to manage all of that. And again, this is all happening spring into fall of your second year. So you're kind of taking over chief duties while trying to figure out where you're going next year and spending a lot of money that you don't have. So for example, I was in Northern Virginia. I was interviewing at programs in California, Phoenix, Ohio. It's like I'm just flying back and forth. It's expensive, and yeah, it's difficult to fund and difficult to keep track of. And again, every program has a different requirement. So some, you had to go out and visit, and then you would have to go back and do the interview in person as well. So then you're doing 2 flights for a program. As far as coordinating the logistics of, turning this into a centralized system, I don't have a solution for that. Maybe at ACFAS, that would be a good option. But yeah, if there could be something done to bring everyone together and make it more streamlined, I think it would be much more fair for both the candidates and the programs, and obviously save money for everybody as well.
I agree with Becca. I think having something that's more centralized, because currently it's a kind of a hodgepodge, and every year it gets earlier, because I think what happens is some programs feel like they missed out on good candidates simply because a candidate was offered earlier, and so then they accepted it. So the next year, that program might move a little bit earlier, so then they have the entire applicant pool versus maybe less applicants or ones that they wanted who were already previously offered. And so there's no like formal timeline from when you're offered to when you need to accept. So sometimes you may accept the first one that you get because you may not know what else you're going to get. And so people may not be in the best situations for them. And so I think having a more centralized process might be a little bit better for the candidate for sure, like Becca was saying.
Yeah. So coming out of residency, Grant, if you had gone just into practice, do you think that you would have felt ready for practice? Or did you feel, I understand what you're saying, you want to get that extra exposure, but do you feel like a 3-year residency, and this is part of a global question that, some people think we should move to a 4-year residency instead. So keep that in mind as part of a more global picture. But do you feel like you would have been ready for practice after 3 years?
I think surgically, starting off probably the smaller reconstruction and working into bigger reconstruction has like my comfort level of being on my own. I do believe so, but as far as like clinic goes, I think I would have to start smaller on clinic. I was fortunate in residency where I was in clinic 2 or 3 times a week and then surgery the other days. So I felt like I had a really good balance, especially my 3rd year. But I still think that there's this large amount of private practice, which is difficult to teach. I think a lot of it's like on your own. And then it also varies because when you get out, every system's different. I have one of my co-residents is RVU, one's at Kaiser, and one's private practice. So all of their billing looks significantly different. So it's harder to figure out like what's the best system to teach. I do feel like I am prepared to start on my own, but I think my proficiency and my ability to hit the ground running is going to be significantly higher coming out of fellowships than it would be out of residency.
What about you, Becca?
I agree with everything Grant said. I think coming out of residency, my focus in residency was surgery. So we operated every day and that was it. And I got almost no clinic. So that transition would have been very difficult for me. And it's still difficult for me here. Sure, you can fix the patient, but can you actually diagnose them correctly and get them to the operating room? I think my favorite thing to kind of say about fellowship is like being an attending with training wheels. So I'm functioning like a 1st-year attending, but I don't have to ask these patients to come in to see me. They're coming in to see my attending who's well-known, well-respected. So you're getting, cases under your belt that you probably wouldn't have had access to as a 1st-year resident or 1st-year attending. Same with the volume as well. And then, in clinic, you're seeing 30, 40 patients a day. If you were starting a 1st-year attending in a small practice on your own, I don't think you'd be seeing that. And then I'm running it as it's my own. And basically my attending is there just to tell me when I'm making mistakes and change it for me and do the right thing. And then we just keep moving on. So it's coming out of residency, sink or swim, sure, could have done it. But I think that by doing this 1 year, I'm kind of accelerating my career, my proficiency, my skills by 10 years by doing this 1 year of extra training.
Yeah, I think that's reasonable. When I came out of residency, I didn't even consider fellowship. That was for 2 reasons. Number 1, I didn't feel necessarily like I needed or wanted it. But number 2, there weren't that many fellowships back then. The number was quite limited. And so they're kind of gaining favor with time. And then, as we go on with more fellowships, it kind of muddies the water a little bit, because back before your time, and even back before my time, we used to have 1-year residencies and then 2-year residencies and 3-year residencies. And some of them had rear foot certification and some of them didn't, just based on the quality of the residency. And there was a little bit of confusion when people got out into practice of saying, okay, well, you did a 3-year residency, you must be better than the person who did a 2-year residency, which may or may not be true. Who knows? Maybe it's just an extra year at a terrible residency. I don't know. But now we're dealing with this where if you did or didn't do a fellowship, it's confusing to the hospital system because, well, now you're fellowship trained, but you're not. But you went to this residency and you went to it's just so hard to keep all this stuff together. So I'm in favor of fellowships because I don't think anyone's going to say that additional good training, that's the distinction between like where you guys are and some other fellowships that shall not be named, because I don't even know what they are, but I know they're out there because I've heard of them. The difference between, someone coming out of a 3-year residency and just feeling, yep, I'm ready to hit the ground running, I'm ready to go, I'm well trained, I'm good to go, versus additional training and something that maybe they didn't get. They didn't get total ankles, they didn't get MIS, they didn't get limb deformity or whatever it may be. And that makes a whole lot of sense to further your training from that standpoint. But then there's these other component of people that are just doing a fellowship, maybe because they feel like they are supposed to, or I'm not sure what everyone's thought process is when it comes to fellowships. Do you guys have other friends, classmates, whoever, who are also doing fellowship?
Yeah. I mean Grant, my friend, obviously doing fellowship with me.
Right. Is it becoming...
Oh, sorry, go ahead.
Oh, I was just gonna say, I mean, I don't think it's helpful for the profession to, for residents to think that they need to do a fellowship. I think in certain cases it makes a whole lot of sense for certain people. Like I said, I'm gonna keep harping on it, especially at good fellowships where you get advanced training in something that you weren't offered in. But I think it's a little slippery slope for residents to think that they need to do a fellowship. But I didn't go to XYZ residency. There might be residencies out there that probably aren't maybe very good and they don't feel like they were well trained. You guys were obviously both well trained and you're taking the extra step. I'm just trying to make this all make sense from my standpoint, because we're in kind of a transitional zone right now of trying to figure out what makes sense. Would you guys be in favor of grant a 4-year residency? Do you think the additional year is what makes the difference, or just the difference in attendings and location and style and all that makes the difference for you?
I think it's more so the difference in style and the attendings and the mentorship than it is like that extra year. Because if you come from a bad residency programming and then you go to an average fellowship, that's still an improvement in that skill set. And so I think Becca and I only applied to a select number of programs because we wanted to advance our training. And we didn't want to take that extra year and just have another 4th year of residency. And so having that area that would increase our skill set and our mentorship and different thought process is the reason why we chose to add a select number of programs. Mm-hmm. I think it's really hard when you take a look at all the programs and say, hey, like maybe we should skim down on the fellowship, because yes, they are helping people, but I think it's just really hard to define. Yeah, there are the ones that are specific to total ankles and for limb deformity or MIS, and some are just increasing proficiency of skill. But I think you do need that increase in proficiency of skill for the people who maybe didn't get the best training in their residency. So I think for those individuals who want to advance, I think it's good for them.
Yeah,
what do you think, Becca?
I agree. I loved my residency. I loved my 3 years there. I would go back anytime, but this additional year is nothing like residency year 4. I'd say the amount that I've grown in the last 3 months is more than I would have in a full year of a 4th year of residency. Whether it's the move, the location, being in an entirely new system, new attendings, new ways to do procedures, that all adds to it and it forces you to grow outside of just as a doctor. But also, I think it's just the kind of like the time mark of graduating. It's just separating between being a resident and a fellow. You think of yourself differently. I'm a fellow now. I need to make the decision this way. I need to be less reliant on, what my attending told me in the past and learn how to figure this out on my own. I think that distinction is really important, separating the years apart.
Sure.
Yeah, and even
yeah, go ahead.
Oh, like Becca and I are fortunate is we have each other at this fellowship. So we have someone to sound ideas off of. But a lot of the fellowships, you're by yourself. And so I think what makes it significantly different than residency and more like being an attending in first year is the fact that, hey, you're kind of on your own. Like you don't have the other residents as much to bounce ideas off of. You haven't been in the system for now your 3rd or 4th year. And so now you're transitioning. And so that transition, I believe, is going to make the next year's transition much easier too.
Yeah. So one of the kind of downsides that people have to be aware of is the loss of revenue, I guess we'll call it. So obviously fellowship pays closer to residency than it does to an initial attending surgery. So instead of earning, my first contract was for 180 with a bonus structure. You guys are what, somewhere in the 70s? Yeah.
Yep.
So, which is perfectly fine. It's not a bad thing. You just have to be aware that there is a sunk cost associated with agreeing to do that. And so you guys are willing to say, hey, I understand that, and I'm making this somewhat sacrifice, I guess, to better myself and better my training. So that is one component of this that does factor in, that people at least need to be aware of. I don't think it's gonna deter too many people if they're set on doing a fellowship. I don't think that is a deal breaker.
I was gonna make a point to that. Becca and I were talking a little bit about that over the weekend. Was the fact that it isn't like we've been in practice for 5 years and we go from that salary and then cut it down to $70,000 again. We don't know any difference financially, and so a lot of it's a continuation as far as financial mindset from residency. And so there isn't that, like, I feel like I'm missing out, but I also don't personally have circumstances where I need to make that large paycheck right now. And so I can delay it a little bit. And I do think, like, with the amount of building that I'm learning here, that's not on my head. I don't feel like I will leave as much money on the table my first or second year, where there is a potential chance that, hey, if I do get in a good system, I can make a large sum of that money back. Although we both know that going to fellowship doesn't guarantee that you're going to get this phenomenal job. But we think at the end will be much better than where we would without a fellowship.
I agree. I don't think it guarantees you a great job. I mean, on my end, I've been involved in hiring, so I know what it's kind of like, and don't necessarily put too much emphasis on fellowship or not. But by nature of doing the fellowship, you will be better trained, and that will be beneficial to you, and you will by nature get a better job than someone who didn't do fellowship. Not because of the fellowship, but because you're better trained and you went to a good residency and you are, likable, and that's why they picked you as the fellow, right? It's kind of a self-selecting proposition that gets you down the line that you're going to end up in a better situation than some other people. But I don't know that it's directly due to the fellowship, and it's certainly not going to hurt. So the biggest downsides, let's talk about downsides of fellowship for a minute. Not necessarily with your guys' fellowship, but some of them out there. I think the concern from an outsider's perspective, right? That's me. I didn't do a fellowship. Is that some of the fellowships are taking advantage of people. They're essentially getting cheap labor to come into their office, see their patients, do their op reports, do a bunch of work. It's basically an associate in their practice for very, very cheap, which is great for them. And maybe it's okay for the fellow, but it feels like they're kind of being taken advantage of. What are your thoughts on how we can somewhat prevent that, Becca?
Grant and I are fortunate that's not the way it is here. But again, I've heard of other programs where the fellows are acting, they're in charge of the residents and they're taking the call for the attendings and doing the dirty cases overnight, and more regulations, I guess. I'm not really sure. It's just that was something that I was aware of, and I knew to look into fellowships that didn't have that sort of attitude or atmosphere.
What do you think, Grant?
I think it's partly the vetting process of whatever certifying or recognizing organization to help ensure that that isn't the case. And then it's also partly on the due diligence of the prospective fellow to make the decision for them, because to figure out what system that they want to be in. Because some are with residency programs, some are without residency programs, some are only one person attendings, and others are multiples.
Yeah, so I think it may go back to that centralized thing that we were talking about earlier. If we centralize them, we get an accrediting body. Honestly, I don't really care if it's ACFAS, CPME, or whoever. but one accrediting body that, does site visits and shows up and checks logs and figures out, okay, are you actually doing what you promised, or are they not getting that same experience that you promised them on the front end, and holding them accountable. I think that's what's probably going to happen in the future, and I'm not the overlord of anything, even in my own house. So that definitely won't be something I'm doing, but it's easy to kind of say that we should do that without having any power to actually do so. But I think that would protect some people from situations where they might get into something that wasn't actually all sunshine and roses and not what they thought it was going to be, and they're kind of being taken advantage of. So I think that's kind of, from an outsider's perspective, one of the drawbacks to fellowship. And if we can keep that out of it, then I don't see any reason why good fellowship can't continue to grow. Now, some people might argue that we are failing. That's probably too harsh of a word. We are under delivering on the residency experience. If after 3 years we aren't providing all of the things that we need to be able to provide for the residents to go out and be successful, then we need to reevaluate the residency programs and say, hey, why are they not preparing? Again, you guys are different because I know your residency programs. Shout out Dr. Schindler. What's up, Drew? How's it going, buddy? One of the attendings at Legacy was one of my third years when I was a first year at UPMC. So shout out Dr. Schindler. You guys went to good programs. So we're not necessarily talking to you, but I don't know. Do you guys have thoughts on any of that stuff, Becca?
Yes, I would. What would you say the general question is again? I'm sorry.
I don't know. I'm just talking in circles.
Yeah.
Thinking about hanging out with Drew. It's just kind of trying to hold the whole situation accountable and figuring out whether residencies are doing what they're supposed to do. Is that why people are seeking fellowships more and more? Again, not necessarily. Let's take the top 10% of the fellowships and just put those aside, because they provide a unique experience. But a certain subset of the other fellowships, are we just letting residents down with poor residency experience and they don't feel ready to get out there? Should we be holding the residencies more accountable to get to the point where there are only 10 fellowships or something that are special?
Yeah.
Or do you think we go the other way and do more fellowships because they provide something unique?
My gut would be leaning toward more fellowships. My experience from talking to my friends, at my program, residents, coming up that are years below me, and then my friends from other programs, no one is saying, I feel undertrained. I feel like I didn't get enough cases. I feel like I don't know what I'm doing. That's why I'm doing a fellowship. I haven't heard that. That might just be the group of people that I'm with, but everyone that I'm speaking with just wants to be the best, wants to advance their training, wants to do more for the patient. So I think it's really positive in that sense, why most people are seeking fellowship.
Which is good, and that's what we want. We want, as a profession, to be, in order for us to be taken seriously as good physicians and surgeons, we want all of our training to be good. We want all of our colleagues to be good. We don't want bad residencies out there putting out bad physicians who are giving the rest of us a bad name. So just so we're all clear, we want good residencies out there. What are your thoughts, Grant?
I'm actually going to take the other side of the aisle from Becca on this one.
Whoa.
I always think about, like, hey, yeah, the top 10%, if we take off the top 10%, like, then what's left? But if we increase the bottom and we make the bottom and we make the bad residencies either go away or we make them better, you're going to increase the overall skill set of the body of podiatry as a whole. I mean, wasn't that the goal of changing all the residencies to 3-year surgical residencies with minimal competency surgeries? So if we increase the bottom, then as a whole, podiatry becomes better. And then I'm fine with the number of fellowships, but also making sure that those are specialized. Some might go away because then, you may take away some of those fellowships that aren't as beneficial. And so I think if you increase the bottom of the residencies and the skill set of the residents overall, you may not need as many fellowships and they might become more specialized.
I think another way to attack that, though, and this might be controversial, is to kind of diversify how we can label ourselves within the field. Right now, a podiatrist is a podiatrist is a podiatrist. You're a DPM, no matter if you do total ankles or all you do is cut toenails. And we've kind of forced everyone into surgical training, which sure makes it a surgical profession overall. But I have many great friends who never wanted to do surgery, and they finished their surgical residencies, and they have outpatient cosmetic nail clinics, and they are doing just fine, and they're very happy with what they're doing. And I think that's a great profession to have. But that person on paper, maybe we should find a way to differentiate that person from someone who's doing advanced Charcot reconstruction. And in that sense, maybe there should be differing residencies in a sense, so people can get the training that they want, and the outside MDs, DOs can understand how we're trained and who can do what.
Yeah, I don't think that's controversial at all. Or maybe it is, I don't know. But I don't think it's controversial because I agree with you. But so I recently had on Randy Clements, who is the director of the Carilion Clinic in Virginia. The episode hasn't aired yet, but it will by the time people are listening to this. So if you're listening to this, go back and listen to the episode with Dr. Clements from Virginia. But he was talking about the very same thing and talking about moving towards surgical residencies and non-surgical residencies, which is very ironic because that's how it used to be. And then we made this push to say, hey, we're all surgeons, which not all dentists become OMFS. I don't even know if that's the right track, but not all dentists become surgeons. And not all orthopedic doctors even become surgeons. They do sports medicine, non-op injections, physicals, and things like that. There are lots of professions that some of them become surgical and some of them do not. And so I don't think that's a horrible idea. You kind of have to think it through and figure out, well, what if, I'm making the numbers up, but what if 300 people want to be a surgeon, but there's only 250, and those extra 50 would have been okay or good surgeons, but there weren't spots available for them. It's a little tricky, and things don't happen quickly. When we transitioned from 1 and 2 to 3-year residencies over time, that happened over the course of many, 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 many years. So I don't know what's going to happen. Again, I'm not in charge of anything, so I can say things all I want, but nothing will actually change. But I think it's interesting to think about because I agree with you. Not everybody who goes to podiatry school can and should be a surgeon. There should be something that distinguishes them. But I feel like somewhere along the lines, we've entitled them to say, well, you got into podiatry school, so that means you will be a surgeon if you want to. And you'll watch them, and then you're like, no, you stop. You're not, this is not for you. Let's get you into something else, right? And so it's really difficult because at the end of the day, we're only as good as the rest of our profession in the eyes of whoever else is evaluating and looking at that. So I think it's interesting to think about. I don't know that it's an easy or an overnight solution, but it's interesting to bring that up because Dr. Clements brought that up as well. So, Becca, when you are thinking about next year, how are you going to attack the job search? When and how?
Right now, it's something. So I want to work in an ortho type group or a hospital setting or a podiatry group. I think the most important thing for me is that it's a well-managed group with the kinds of patients that I want to see. So I like outpatient recon. I like deformity correction. So I'll be looking for practices that can offer that to me rather than the specific type of practice to apply to. Regionally, I think the best thing to do is to be open, especially if you're like me. I'm starting what I'd say is a little late in October versus I think, Grant, you started in July, if not in your third year of residency.
We're at the same place.
Good. But basically, I'm looking for any open foot and ankle ortho or podiatry job that's surgical in an area that I would want to live. And for me, that's somewhere on the East Coast or here, not the Midwest.
Yeah. What do you think, Grant?
I think looking for a job, it's using connections, it's maybe trying to find recruiters or reaching out to programs and see where people are hiring. I think it's difficult. I mean, I've had, a couple interviews at this point, and some are like, hey, you can't take general ortho call, and so we can't move forward with this, and which is completely acceptable. And I understand that. But I'm kind of all over where I would do Midwest, Mountain West, Pacific Northwest, and so I think it's trying to cast a broad net. I think it makes it a little bit harder when you're only looking in one area. You pigeonhole yourself a little bit, but it's also a little bit hard when you can look at everything and every option now becomes a chance. So I think is looking when you can and building connections and using those connections.
Yeah, I think networking connections are a big part of it. When I was looking for a job originally out of residency, I picked an area that I wanted to be in, and I started cold calling a lot of offices. If you wait for someone to, I'm talking not to you guys, I'm talking to any other listener. If you wait for a job to get posted, they will have 500 applicants, and you will just be another piece of paper in a stack on a desk, because good jobs that get advertised go quickly. And so I would cold call a bunch of offices and say, hey, this is Dr. Dikis, which was true, even though I was a resident. Can I please speak to the office manager? And they don't know. They're like, oh, yeah, hey, hold on a second. And then I went through and I just said, hey, this is me. I'm looking. I'd be really interested. Do you know if you guys are going to be hiring? And sometimes that works, and sometimes you get a call back, and sometimes you don't, and sometimes you create a pathway that isn't there originally, but then later in life it works out that does become a reality. So my wife and I found jobs in a very different way. I was looking at jobs in the Midwest, working with a recruiter. The recruiter said, hey, do you want to go to Tennessee? I said, absolutely not. You want to go check it out? I was like, okay, fine, let's go check it out. And I checked it out. It was an ortho group. It was awesome. We had a great time. And then we moved to Tennessee, and my wife sent a letter. Think about that. A letter, like with a stamp, like in an envelope, mailed it. Yeah, she does. I don't know how to do that. She mailed it to the CEO of a hospital, and they said, yeah, we used to have one, but we haven't had one for a while. Come on in for an interview. And they hired her. So you never know how you're going to find your job. So I'm mentioning that to people that are listening. You guys are starting and kind of in the middle of that job search, but I don't want to say don't take no for an answer, because at some point, yes, take no, go away, leave them alone. But create some connections and reach out, and you never know what you're going to make of that. So, Grant, I don't think you mentioned exactly what type of practice. Are you looking ortho group or hospital, or you're kind of open?
Kind of open. I would probably lean towards like a multi-specialty group or a hospital group. I really like the fact of having other people around me from other specialties, just having those conversations day in and day out. I would go crazy if it was just me.
Yeah. So I'm in a multi-specialty group, and I used to work in an ortho group, and every ortho group is different and every multi-specialty group is different, but I really, really like my setup right now with the built-in referral pattern from the family practice providers and having some collegiality. I work my office. Well, we have a PA, and then it's orthopedics, and then it's general surgery, and we're all in the same office. We all work together, and it works out really well. So, Becca, do you have any advice for residents that are looking into fellowship right now? So what is your kind of one or two pieces of advice for them?
I think, well, one, I don't know if this is the best advice, but start now, right? It's October. Make your list, figure out where you want to go, figure out what you're interested in and why you want to pursue fellowship. Everyone's going to have a different path and reason, like we talked about, for pursuing that. So just make sure you understand why you're doing it. And two is just read everything. The interviews that you go on, you can answer a question, you can read an X-ray, tell them what you're going to do. But if you can't answer why with literature, your answer means nothing. So read absolutely everything and figure out your treatment algorithms and back it up.
How about you, Grant?
I would say figure out what you're good at, and either continue to go down that road, or else figure out what you are potentially weak in, and then trying to enhance yourself as a complete surgeon that way. So figuring out what you really like to do, maybe getting away from the things that you don't want to do. I don't really want to clip toenails my entire life. So I know that's something that I'm going to move away from, and trying to figure out like, hey, okay, this is like a clean practice where everything moves really efficiently. And that's kind of the idea that I wanted to go with. So I like the fact of doing clean procedures, managing arthritis, something like that. And so it made, fellowship for the ones that I applied to really attractive.
Sure, absolutely. I think you guys have been a good source of information for people that are potentially interested in looking into the fellowship process. So I appreciate you guys joining me tonight.
Yeah, thanks so much for having me
here.
Well, thanks everybody for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
See ya.